thought I would do like a little like study with me, slash me explaining, because you guys really like medical information, I guess. So let's start. This is a rheumatology quiz. Rheumatology is the study of autoimmune inflammatory diseases, mostly. So the first disease we're going to talk about is rheumatoid arthritis. Rheumatoid arthritis is a autoimmune inflammatory disease that affects mainly women, middle-aged. Okay, hold on, let me scroll up. I don't want to miss anything. Okay. This is something that's a gradual onset. Okay, this isn't something that you just wake up and you're like, ah. This is something that's going to happen over weeks to months. Okay. The main findings are going to be symmetric, meaning equal on both sides. Okay. Distal, peripheral, meaning away from the inside. Like your fingertips or whatever. Arthritis or arthralgias or pain and inflammation of these joints. The main ones for rheumatoid arthritis are going to be your MCPs, which is your metacarpal phalangeal joints. That's going to be between your metacarpals, which are these bones here. These are your carpal bones, metacarpals, and then your phalanges. Usually you have three, so this is your distal phalange, middle phalange, and your proximal phalange. Your thumb only has two, distal and proximal. So it's like joints here. These really can hurt. Okay, it can also affect the PIP or the proximal interphalangeal joint. So that would be here versus the DIP. Rheumatoid arthritis does not affect this. Okay, the DIP is spared. That's like a thing you need to know for rheumatoid arthritis. As another thing that's associated with any sort of inflammatory arthritis is going to be prolonged morning stiffness. So you wake up, you're super stiff in your joints. Okay, but if you get moving, they settle down and relax. So activity actually helps the stiffness, whereas non-inflammatory arthritis, something like an osteoarthritis, your run-of-the-mill osteoarthritis, that's going to be a shorter morning stiffness, and activity actually makes it worse. So that's something to know. Rheumatoid arthritis also has extra-articular manifestations, meaning extra outside of articular joints. So outside of the joints, it can also affect other things. But the main thing you want to know is it doesn't affect the kidney. Some of these other diseases we're going to talk about, they do affect the kidney, but rheumatoid arthritis does not. It spares the kidney, and it spares the DIP. One of the extra-articular manifestations is with the eye. You can have episcleritis or scleritis. Episcleritis is the better of the two. Episcleritis is non-painful and it cannot cause blindness, whereas scleritis is painful and it can cause blindness. So that's something to know. You're also going to have like fevers, fatigue, meaning tiredness, weight loss, depression. It's a tough disease. So any of you gals or guys out there who may have rheumatoid arthritis, props to you guys. It's not an easy disease to have. You can also have an associated syndrome called Sjogren's syndrome, which is a lot of dryness, dry eyes, dry mouth, dry vagina, dry anything. Okay, dry skin. Another thing that can happen is you can get these nodules. A lot of times this is a later stage of the disease. A lot of times on your extensor surfaces, a lot of times like a really nasty nodule on your elbow. You can also have pulmonary fibrosis. So this is fibrosis in the lungs. This is usually more in men. Yeah. You can also have pleurisy, which is inflammation of the pleural, which is the linings of the lungs. Again, in males, you can have pericarditis, which is inflammation of the heart. This is, again, it's actually more of a common thing in rheumatoid arthritis. You can have associated malignancies like lymphoma or leukemia. Pardon me. You can also have rheumatoid vasculitis. Vasculitis is inflammation of the blood vessels, so a lot of inflammation. Obviously, as I said, rheumatology is the study of inflammatory autoimmune diseases. One of the major subtypes of rheumatoid arthritis is a very severe type. infection. Felty syndrome is serious, and it's a severe form of rheumatoid arthritis. The main laboratory findings with someone with rheumatoid arthritis are going to be a positive rheumatoid factor. Positive rheumatoid factor is a sensitive test. Tests can either be sensitive or specific. Sensitive means if I send 100 people in with rheumatoid arthritis, probably all 100 are going to have a positive test. Specific would be if I sent 100 people in where only 50% of them have rheumatoid and 50% of them are normal. Only the 50% with rheumatoid would have a positive. That's a specific test, meaning only people with that disease will have that test. So rheumatoid factor is not a specific test, it's a sensitive test, so it's something that you can use to screen. I mean, not really, but like it's something that if they don't have a positive rheumatoid factor, odds are they don't have rheumatoid arthritis. The specific test for rheumatoid arthritis is an anti-citrullonated peptide or autoantibody or ACPA or anti-CCP. It's got a couple names. This is going to be something that's specific to rheumatoid arthritis. So if you have a positive anti-CCP or a positive ACPA, odds are you have rheumatoid arthritis. Looking at imaging, x-rays are really helpful. We can look at your joints. We're going to see some soft tissue swelling, some osteopenia, meaning low density of the bones around that area. In late stage rheumatoid arthritis, as we talked about those nodules, there's some other things that can happen. There's a couple deformities. There's the swan neck deformity, which is you're going to have hyperextension of the PIP. So this, I can't even do it. This would be bent like this, and you would have like that. That's swan neck. Boutonnieres is like this. They're opposite. So hyperflexion of the PIP, hyperextension of the DIP versus hyperextension of the PIP, hyperflexion of the DIP. You can also have something called volar subluxation, which is when parts of your joint actually like fall down, kind of like that hyperextension I was talking about, but it's kind of just like one part would go down. So one bone would go down like this. Not good. So we can look at that on an x-ray to see. An MRI is more sensitive for things like that, so we would see more. Treatment for rheumatoid arthritis can start off on NSAIDs, things like ibuprofen, naproxen, indomethacin, things like that, okay? A lot of times those need to be higher doses, so like prescription doses, so things you would get from a rheumatologist or your primary doctor. If those don't work or you have a really nasty flare, we can use steroids, okay? Steroids should not be used long term, but a lot of people with really severe autoimmune inflammatory diseases, a lot of people are on long-term steroids. It's really sad. You can even get intra-articular steroids, so if there's a specific joint that's really inflamed at a certain time, we can actually inject steroids into the joint. And our mainstay treatment in rheumatology is something called the DMARDs, the disease-modifying anti-rheumatic drugs, DMARDs. There's a couple different classifications of DMARDs. There's the synthetics and there's the biologics. Synthetics are obviously synthetic. They are man-made, okay? Some of the ones you may have heard of, methotrexate, that's a big one in rheumatology. It's used for a lot, specifically rheumatoid arthritis. It's kind of like our start off for a lot of our inflammatory diseases. Another one is hydroxychloroquine or Plaquenil. You probably have heard of this for COVID. It's really used as an anti-malarial drug, so malaria, it treats malaria, but it's also used in a lot of these rheumatoid rheumatic diseases. So when there was really no evidence out that it was going to help or hurt COVID, and people were still trying to get it, these poor patients with rheumatologic diseases, they were suffering because they couldn't get their actual definitive treatment. Some other ones would be sulfasalazine, azathiopurine. Those are our synthetic, our conventional synthetic DMARDs. And then you move over to the biologics. Biologics are a little more severe, okay? These are usually antibodies made against antibodies or against some sort of inflammatory thing. So we have our tumor necrosis factor inhibitors. These are drugs that actually go against some of our inflammatory mediators, our signals that tell our body to be inflamed. We can actually attack those systems. Yeah, these are all TNFI, or yeah, TNFI I call them, but TNF inhibitors. Then you have your interleukin inhibitors. Again, these are those inflammatory mediators. This is stuff like Kineret, Actemra, Taltz, or Cosentyx. We have some T-cell inhibitors. The main one is Orencia, and we do have B-cell inhibitors, which is Rituxan or rituximab. So those are more like severe treatments for a lot of these. So that's rheumatoid arthritis. Moving on to juvenile idiopathic arthritis. This is a kind of like a general term for a lot of our juvenile, meaning young person, inflammatory joint arthritis, autoimmune inflammatory arthritis. So these are usually earlier than 16 years old. It's arthritis that lasts greater than 6 weeks, and our mainstay treatment is really just NSAIDs for the little kids. So the first one is called oligoarticular JIA, or juvenile idiopathic arthritis. Oligoarticular means less than or equal to 4 joints affected in 6 months. So it's not too many joints, it's less than or equal to 4 joints, okay? This is our youngest population of juvenile idiopathic arthritis patients. They're pretty young. For this one, you're going to notice things like your baby was, normally waking up in the crib, standing up, crying for mom, crying for dad. And now, baby's not getting up. They have really bad morning stiffness. You can also see iritis or inflammation of the eye with these types of patients. Again, NSAIDs are the treatments. Then we move on to the polyarticular, so more than 4 joints affected in 6 months. And that can be broken down into 2. We were talking about that rheumatoid factor. These patients can have rheumatoid factor either positive or negative. So it's seronegative or seropositive polyarticular JIA. So the first one we'll talk about is seronegative polyarticular JIA. As we said, greater than 4 joints affected in 6 months. These are kind of middle. It's not our youngest patients. It's not our oldest patients. Kind of right there in the middle. These are large joints, the knees, things like that. And with these patients, we see poor weight gain and poor growth with these young patients. Moving over to the seropositive polyarticular JIA. This is our oldest patients. This is very, very similar to rheumatoid arthritis. Okay, so a lot of the same things, greater than 4 joints in 6 months. It's an aggressive, erosive disease process. They can have Felty syndrome, which we talked about, is that neutropenia, splenomegaly, and arthritis. They can have the vasculitis, and they can have the nodules. A lot of these JIAs, they resolve before patients get to school age, but seropositive polyarticular JIA is kind of makes up that can be quite tough. And the last one of the juvenile idiopathic arthritis is systemic onset JIA, or Still's disease. Okay, this is systemic, meaning like the whole body gets affected with these patients. So they have an intermittent fever, meaning a bunny ear or a spiking fever. During the day, it's going to go high, it's going to go low, it's going to go high, it's going to go low. It's like all over the place. We need that for more than 2 weeks, and arthritis for more than 6 weeks. That's kind of like the sign of systemic onset. They also have a transient, meaning not permanent, salmon-colored rash that goes and comes. They also have myalgia, which is muscle pain, a lot of muscle pain with these poor patients. And they also have a possible really severe complication called macrophage activation syndrome, or MAS for short. This is when the body gets really overly, pardon me, I'm having my coffee, overly inflamed, and it's this nasty side effect that can be like multi-organ failure. They can really die from it. It's when that intermittent fever becomes constant, a constant fever, and when that rash is no longer transient, it's like, full-time constant. There's not any really definitive treatment for macrophage activation syndrome, so it's really just like a thing we fear with these poor patients. So that's it for the JIAs. Now we're going to move on to the spondyloarthropathies. These are autoimmune inflammatory arthritis that affect the spine, the hip joints, tendons, insertion. So like, think about your Achilles tendon going into your heel. That's a spot that can get really inflamed. We said that. Finger joints, we can get something called sausage finger because these tendons right here can get really inflamed to get puffy. And you can also have uveitis, that inflammation of the eye. So those are the 5 characteristics of these family of diseases. So the first one and the most common is called ankylosing spondylitis. You may have heard this. The kind of buzzword for this is bamboo spine. So this is something that's associated with a gene called HLA, or human leukocyte antigen B27. This is more of a, I would say, a sensitive finding because it is not only found in ankylosing spondylitis, but it's found in, I believe, let me just make sure before I say it. Yeah. So it's also found in enteropathic arthritis, which we're going to talk about in a second, and reactive arthritis, which we're going to talk about in a second. So it's not specific to just ankylosing spondylitis. It is associated with a lot of autoimmune inflammatory diseases, but it's something to know that it's associated with that. With these patients, you're going to have nocturnal, meaning at night, really bad, deep lower back pain and buttock pain. It's so bad that they have trouble sleeping. That's kind of like the telltale sign with these patients. They have tenderness with direct palpation on that lower back, the sacral area, really bad pain. They have trouble with extension in the thorax, meaning the chest region, and the neck. They eventually become hunched over, forward, flexed, okay? They also have a bilateral sacroiliitis. Sacroiliitis is inflammation of the sacroiliac joints, which is between your sacrum and your iliac, or your ilium, which is, ilium. It's between the hip and the sacrum, which is part of the spine. So you're going to have that on both sides, bilateral, and this is one of the things because a lot of these other spondyloarthropathies have only one side, or bilateral, not bilateral. What is the opposite of bilateral? I'm having a brain fart, girl. Give me a sec. Asymmetric. No. What is the fucking word? Girl. Bilateral versus unilateral. Girl, send me to hell. I can't believe I forgot that. Okay. So back to ankylosing spondylitis. These patients, as I said, they have trouble with that extension. So with that forward flexion, we have 2 positive tests that can happen. One is called the Schober test. This is a test where we're going to make 2 marks on the back of the lower back of a patient, and then we're going to have them try to move forward as much as we can, and we're looking for a change in distance. If that change in distance isn't big enough, or it's too big, that's a positive Schober test. The next is the fleshy or occiput wall. This is where we're just going to have you like go straight up against a wall, but because they have that forward flexion, the back of their head, their occiput doesn't hit the wall, and that's a positive test. These patients, as I said, have that positive HLA-B27, but this is something interesting. They do not have a positive rheumatoid factor or a positive ANA. These are really sensitive tests for a lot of autoimmune inflammatory diseases, so they don't have these. A lot of these, or all of these really, these spondyloarthropathies are actually called the seronegative spondyloarthropathies because they don't have a positive rheumatoid factor or ANA. The most specific test for these is going to be an X-ray of those sacroiliac joints, and as I said, these are going to have bilateral sacroiliitis, or inflammation of the SI joints. You're also going to see with the spine some squaring of the vertebral bodies. So it usually is kind of like these round things, and now they become really like squared. And they also have bamboo spine where they actually fuse together, and a lot of these patients can't bend at a certain point. The first treatment for these patients is going to be NSAIDs. Again, ibuprofen, naproxen, indomethacin, things like that. If those don't work, we're going to move to those synthetic DMARDs. Sulfasalazine for this one is kind of the first one you're going to use. You're not going to use methadone. those. They're going to have psoriasis, obviously, and they're going to have psoriatic nails, which is going to be signs that the DIP joint is affected. If the DIP joint is affected, we're going to see problems in the nail. You can have ridging, pitting, or I think it's called onycholysis, which is like this, like turning upward, this like peeling. They also have unilateral sacroiliitis. So as we were talking about those SI joints between the spine and the hip, it's just one-sided. You can also see inflammation of the eye, iritis, and oral ulcerations with these patients. As we said, these patients are not going to have high rheumatoid factor or ANAs. We can look at the X-ray, and we are going to see joint space narrowing, ankylosis, and we're also going to see in late stage something called a penciling cup deformity, where normally our phalanges, these three bones right here, they're nice and like kind of like rounded rectangles like this, but what happens, instead of them being like this, coming together and like a little bit of joint space, one of them actually looks like this, and then you see this like penciling cup deformity. You can also see something called arthritis mutilans, which is end stage psoriatic arthritis, and you get this like telescoping of the joints. You can see whiskering and a fluffy periosteum also on X-ray. Again, these are going to start off with NSAIDs high dose, and then it's going to move to those synthetic DMARDs. And with the psoriatic arthritis, you're going to use a high dose methotrexate. So as opposed to ankylosing spondylitis, where we don't use methotrexate, psoriatic arthritis, we do use methotrexate. And if that doesn't work, we can use pretty much all of those biologics we were talking about. Oh my gosh. Then we have enteropathic arthritis. This is going to be arthritis associated with inflammatory bowel disease. Okay, this is Crohn's disease or ulcerative colitis. A lot of these patients, 20% actually of patients with IBD have this enteropathic arthritis. It's going to affect both the axial, meaning the spine, or the peripheral. Axial, you're going to have stiffness in the back and butt, which is very similar to the ankylosing spondylitis. This pain is going to be alleviated with movement, like a lot of these inflammatory arthritises, but this is not associated with your inflammatory bowel disease. If you have a flare of your ulcerative colitis or your Crohn's disease, it's not going to really flare up your arthritis versus the peripheral disease, arthritis outside in your hands, fingers, feet, whatever. That can be associated with inflammatory bowel disease activity. This is associated with a positive HLA-B27, as we said earlier. This does affect the sacroiliac joints, usually unilateral. We're going to check the X-rays for this to make sure that it's not bilateral, because then we would say it's more ankylosing spondylitis. NSAIDs are the first treatment for this. We can use something called a PPI associated with it. This is like our antacids, really high dose. It's the most potent antacids we have because they have GI or gastrointestinal issues with their IBD, their inflammatory bowel disease. We can use this to help prevent any more irritation. Then we can move to those synthetic DMARDs. Sulfonylurea see that unilateral sacroiliitis, as I said. You can see periositis, which is a fluffy periosteum. Treatment for this is going to start with their NSAIDs, steroids, antibiotics if they're still infected. We're going to move to those synthetic DMARDs. We're going to start with sulfasalazine. That's going to be your mainstay over methotrexate. You can use methotrexate, but sulfasalazine is more helpful. However, this is a mild self-limited disease, so hopefully it'll go away in 3 to 5 months with treatment. But it can become chronic if you have a positive HLA-B27 family history of this and an inflammatory bowel disease. So that's pretty much it for our inflammatory spondyloarthropathies, as we were talking about. Now we're going to move on to something called gout and CPPD, or pseudogout. So gout and pseudogout come from a long progressing hyperuricemia, meaning a high level of serum uric acid. So a lot of serum uric acid, which is high uric acid in your blood. Okay, this can happen if you're not excreting, meaning your kidneys are not getting rid of enough uric acid, or you're just producing too much. Hyperuricemia on its own, you're not going to have any signs and symptoms. After about 10 years of this, you can get something called acute gouty arthritis. This is going to be like abrupt onset of really exquisite pain, usually in your first MTP, which is going to be like this joint right here, but in your foot, and it's going to be your first one's your toe right here. It's called podagra. It's a really bad pain, so much so that people say they wake up in the middle of the night because the sheets are hurting their feet because it's this really inflamed, really inflamed joint. Okay, but the triad associated with gout is going to be hyperuricemia, acute monoarticular arthritis, as we said, podagra, and a response to colchicine. This is a new drug, colchicine. We haven't talked about this before. This is used for these two diseases right here. We'll talk about it in a second. Okay, this first attack of acute gouty arthritis, it's gonna resolve on its own, maybe 10 to 14 days. So let's say a patient notices it goes away, whatever, they don't say anything about it. Then they go into this intercritical stage where they're gonna have high levels of uric acid that are waxing and waning, and they might have a second, a third, a fourth acute gouty arthritis. And then after you have your first acute gouty arthritis attack, the second one is most likely going to happen within the first 2 years after your first attack. Then you're going to go into this intercritical stage, as we talked about. And after about 10 years of that, or after about 4 acute gouty arthritis attacks, you're going to go into a chronic tophaceous gout, where you're just going to be in constant pain, basically. You're going to have these non-tender, flesh-colored, or yellow or white bumps, which is from deposition of these uric acid crystals. Obviously, you can get treatment after your first or second acute gouty arthritis attack, and then you don't have to worry about this, but this can happen. As I said, you're going to have high serum uric acid, greater than 6.8 milligrams per deciliter. And if we get a synovial fluid analysis, meaning we're looking in your joint, we're going to pull fluid from your joint while it's inflamed. We're going to see leukocytosis, which is high white blood cells, and we're going to see high PMNs, which is polymorphonuclear white blood cells. Okay, we're going to see urate crystals, because obviously uric acid, we're going to see urate crystals with a negative birefringence, which is like a test for them, and they're going to be needle shaped, so kind of scary. That's why they're, obviously inflamed. If we were to get an x-ray and we looked at your joints, we would see these microtovi, or these small tophaceous spurs, and we would also see punched out or rat bite lesions. Okay, first line treatment for the acute gouty arthritis is going to be NSAIDs, specifically indomethacin is used a lot for gout patients. Then we can use colchicine. Colchicine can be used for the acute gouty arthritis, but it can also be used to prevent further gouty arthritis attacks. It can be used for both. It's the only one of these that can be used for both. After we get you out of your inflammation, then we can use these drugs. They're called urate lowering treatments to prevent it from happening again. The first line is going to be something called allopurinol. Allopurinol increases the amount that your kidneys are going to excrete into your urine. Allopurinol is a sister to something called febuxostat or Uloric. These are the first two treatments that we use to prevent further acute gouty arthritis. If that doesn't work, we move on to probenecid. Probenecid decreases the conversion of like your purine to your uric acid. If that doesn't work, our last line treatment is something called pegloticase or Cristexa. Cristexa is basically just an enzyme that's going to break down uric acid in your body. So it's our last line treatment because it's pretty like severe. Then we have something called Pseudogout. So Pseudogout is similar to gout. It is not uric acid. It is calcium pyrophosphate